Hello, everyone, to the Global Soccer Conclave. The next session for us, newer trends in injury management. And we have an exciting panel with us for a wonderful discussion that will be followed soon. May I welcome Dr. MARGOT PUTUKIAN. She is serving as the Chief Medical Officer for Major League Soccer. She was the past president of American Medical Society for Sports Medicine. She is also a serving team physician for US soccer team and a senior advisor for National Football League's Head, Neck, and Spine Committee. Wow. Dr. MARGOT, please welcome to the Global Soccer Conclave.
Thank you for having me.
Yes. So next speaker we have is Dr. KATHARINA GRIMM. She represents the Sports Equity Lab, which is a research group founded by Dr. Sept in the United States that is investigating in all kinds of inequities in sports. Wow. Including all forms of abuse and use of such approaches for the athlete-centric use to find solutions and engage all the stakeholders for going beyond the paradigm of punishments. So Dr. Grimm is also a co-founder, director of She Sports and She Power Sports, and also works for the World Anti-Doping Agencies, national and regional anti-doping organizations, and international cycling federations. She is the former director of medical affairs at Qatar in Qatar, and also the head of FIFA Medical Office, Zurich. Welcome, Dr. KATHARINA. Welcome to Global Soccer Conclave.
Thank you so much. Enormous pleasure to be here.
The honor is ours. So the next speaker we have is Dr. Anirban Mallick, who is a sports medicine specialist with almost more than 10 years of experience as a team physician with National Institute of Sports in India, which is the premier apex body promoting sports in India. He has worked as team physician for Indian boxing team and hockey teams, and also extended his support to the soccer teams at National Institute. He has numerous national and international publications to his credit and is a routine speaker at various national and international conferences. He's also recipient of prestigious Perfico Award of 21 and Health Professional Awards 2017 in sports medicine and sports cardiology, and is also nominated for BMJ South Asia Awards. So welcome, Dr. Mallick. Welcome to Global Soccer Conclave.
Yeah, thanks. Thanks for having me.
So let's begin the session for today. I'm really excited to discuss a lot of new things. As the theme goes of the session, newer trends in injury management. I remember the incident of FIFA World Cup in Russia in 2018, where the Group B match between the Morocco versus Iran. The Moroccan player Nordin Amrabat, he was taken off the field because of clash of the heads, and then he was reported to have a memory loss and spent a night in hospital. So the question in that a bit of controversial case was his return to play, and FIFA's guideline mandated minimum 6 days of minimum time for return to play after a concussion incident, and he was seen playing on the 5th day. So there was a lot of controversy. FIFA mandated, FIFA was looking into probe that inquiry, but Morocco's decision to allow the player was their own decision after the team doctors ruled out, although FIFA had written in that case, and there was a lot of chaos in that scenario. So though it was being described as a questionable decision, taking to the theme of today, the newer trends in management, and to hear from the best, we have Dr. MARGOT, who was vast experience working with soccer as a chief medical officer. So how do you see it from a team physician's perspective in recent times to recognize the sports related concussions? You're mute.
I'm sorry, I was unmuted.
No.
Well, it's a fantastic question. And I think that recognizing injury and specifically concussion is really a challenge, especially on the sideline for physicians when the play is occurring oftentimes across the field of play and may not be seen. And I think it's important to understand that recognition of injury is just one component of sort of the overall concussion plan. And other components include, education, testing at baseline for players, the recognition of injury, the assessments that are performed on the sideline, as well as then management, including return to practice and return to play protocols. I think that because there, as of yet, is really no clear objective biomarker for concussion, the diagnosis remains a clinical one that's based on pairing a mechanism of injury to subsequent signs or symptoms. And symptoms can be particularly challenging since they're not all specific to concussion. They may be delayed several minutes to hours. And then signs don't always occur. So they're either not present or they're not seen, they're not witnessed. Recognition is also an important responsibility, not only for the medical staff and the team doctors, but also for the players, teammates, coaches, and even the officials. In terms of recent advances to the recognition of injury, I think the use of video replay is likely the one that's the most helpful as a sideline team physician. And a recent evaluation of several professional sports leagues, including the National Football League, hockey, rugby, cricket, found that in association with a direct or an indirect blow to the head, which is the mechanism, that certain observable signs are very predictive of a subsequent diagnosed concussion. And in particular, the observable signs that can help sideline clinicians or team doctors recognize injury include the player that's lying motionless, motor incoordination, an impact seizure, tonic posturing, a player that falls without being able to protect himself, and a blank or vacant look. And so these 6 sort of observable signs have been associated with a very high predictive ability of diagnosing concussion. The technological advance of using sort of spotter programs where video replay is used alongside of these recognizing these mechanisms has really been a game changer in that the spotters are trained to identify observable signs, send a message either via telecommunication or text to the sideline doctor, and subsequently send the video clip and the replay such that the team doctor can view the injury in slow motion and from a variety of angles. This helps the team, the medical team, view not only the mechanism of injury, but then also whether or not there was an observable sign, together improving recognition of concussion. So a long-winded answer to your question, but I think that the use of video replay has really been a game.
Really, it's a good tool these days, and hopefully we can save a lot of concussions by just having a replay. So, Dr. Katharina, we are, from your profile, I feel that you're working more into the non-accidental kind of injuries. Can you explain and shed us some light on those? What are those non-accidental injuries and why are they important to soccer? I mean, what is the prevalence in soccer and how it is becoming up, coming up as a problem or a challenge these days as compared to the,
Yeah, no, thank you for that question. And first of all, congratulations to Global Soccer Conclave that you actually start the conversation on this very challenging topic. That is, many people are not comfortable raising it. So I think I'm really grateful for everyone out there who is attending this session today. So we chose that term non-accidental injuries purposefully because we wanted to use language that is familiar to us as sports medicine physicians, right? So we deal with accidental injuries every single day and we are very passionate about their prevention. But different from what Margot just described with the concussions or an ankle sprain or a hamstring sprain, non-accidental injuries are the result of abuse that may be either verbal, physical, sexual, and or emotional. So a very critical aspect of non-accidental injuries is the severe consequences they have for players' lives. So a survivor of this trauma experience shame and guilt. They feel unsafe and insecure in relationships. They can develop anxiety, depression, self-harm, substance abuse, cancer, and a whole array of chronic conditions that range from neurological, musculoskeletal, respiratory, cardiovascular, and gastrointestinal problems. So the experienced trauma reduces the quality of life and extends long beyond, the actual abuse has stopped. Now, to your question, whether they are a problem in football, sadly, we don't even have, the recognition tools and the data that Margot presented. I wish we had, these signs and tools that we can use. But I think most of us are aware of the hundreds of former players that came forward recently in the UK that had been abused at boys across various clubs in the UK, where now actually some coaches have been convicted and jailed. We also surely all recall the female players that have been forced into sexual relationships by the former president of the Haitan and Afghan football associations. Now, from a scientific perspective, if we look at sexual abuse only, the prevalence ranges from 2 to 53% in different studies globally. And that is mainly because these studies are so difficult to perform. There is no universal definition of abuse. Athletes are not comfortable to talk about the topic, yet they rely on self-reports. So you find low response rates, there's different instrument use and questions, sample size and characteristics vary. So these are inherently difficult to perform. We know very little about African and Asian athletes, but I think there are a number of concerns why this might actually be a high-risk setting. A critical aspect here is the abuser has either perceived or real power over a player. So this might be a physician, a coach, a football official, or an administrator. And this power differential is really an essential feature of abuse. Now, if we consider how much is at stake for the players in our region, where for many it's still a way out of poverty, they dream of playing professionally abroad, we know they will do anything to be on that team and showcase their skills. So they are extremely vulnerable. And there are many other factors such as, the extremely hierarchical structures in our sports organization, the authority figures. And then if you look at the groups that are most at risk, so these are elite players, child and female players, and players with impairments. So if we remember how many amputee players we have in Asia and Africa, due to polio and traffic accident and civil wars, I think we do not know the exact size of the problem, but we have to assume that football is not the safe space we would like it to be for our African and Asian players.
Definitely. So before I come back to the other speakers about the questions, I would like to hear something about the latest approach in prevention and treatment from Dr. Grimm. Like how these, you highlighted about the non-accidental injuries and how they may pose a great problem in coming world. But is there any way of preventing it or treating it, or any of the latest approach that we can have so that all our attendees would be interested in that scenario where they have some tool to overcome these problems?
Yeah, I wish we had. I wish I could give you the SCUT 5 or something like that. But,
I would have loved that if it was a ready-made thing, but I know it's not that easy.
Yeah, I think we have to be aware that this is a very young field where all of us in sports medicine are still learning, and we do not have all the answers at this point. But what we know is that we cannot simply apply the treatment and prevention method that we use in accidental injuries in non-accidental injuries. So we really need to learn from other specialties who practice trauma-informed care for decades, like pediatricians, and their wealth of experience. And I'm afraid there is currently no approach to protecting patients that we can directly apply across all sports medicine settings. but something like the adverse childhood experiences and similar frameworks may provide a very practical starting point. So at the Sports Equity Lab, we are currently composing an expert panel for a consensus on the clinical management of non-accidental injuries. And the question is, how do we integrate non-accidental injuries across the various sports medicine settings in a way that is considerate of players' individual needs and experience? And the first step will always require a culture change in our clinics and consulting rooms and sports organizations, where all staff must be aware and understand the significance of trauma players have experienced. And then in prevention too, I think we need a paradigm shift away from our established models of injury surveillance programs and data capture and analysis. So we were all trained that first we need to define the exact size and nature of the problem, and only then can we develop effective injury prevention programs. But if you remember how massive the impact of these injuries is on players' lives and quality of life, how athletes are committing suicide, I think we might probably want to revert the whole program process and start with prevention.
Yeah, sure. And I think we are privileged to have this topic discussed on our forum here, and we start discussing it further so that our attendees are aware about this situation, that there exists something called as non-accidental injuries, and which is a growing concern in future. And obviously, we'll be coming back to you. But before I move on to the next panelist, you must have seen the Euro 2020 case where the Denmark's midfielder, I don't remember, I think it's Christian Eriksen, yeah. So he suddenly collapsed on his side of game in the opening match against, I think, Finland. So the people who were there at the field side, they said that, yes, he's gone. We didn't see anything. We had to do a cardiac resuscitation. Probably it's a cardiac arrest, and he was taken over to the hospital for the necessary test and all. And after that, the test became pretty normal. And, doctors were like, he didn't have anything. He didn't show anything. So in such scenario, Dr. Mallick, this question is to you, that how do you see the events in recent times, the events of sudden cardiac arrest on a football field? And what are the recent advances if such situation arises? Looking at the global scenario and the Indian perspective, how do you see these events and how to prevent it or take care of it?
Yeah, thanks for the question. It's a very important topic. And the incident that you have mentioned is a kind of a prime example that with a prompt intervention, how we can save the life of an athlete, be it a footballer or any other sports for that matter. But that thing can only be done if you have a proper planning. That thing can only be done if you have all the proper equipments and all the important training that you and your team should have. Now, in case of football, we need to understand one thing first regarding these issues, these kind of things, is that maybe you are a team doctor or a venue medical officer, but you cannot enter into the ground until being summoned by the referee. But there has been a slight change that has been made in football, that in case the player collapses without any contact, then the doctor in charge can, maybe the team doctor again, maybe the team doctor or the venue medical officer, he or she can enter into the ground without being summoned by the referee. So that is one advances that FIFA has done, which is very important thing, so that we don't lose those important time. Of course, the doctor needs to inform the fourth official, but he or she should not wait for being summoned by the referee. So that is one major thing. And when you enter into the ground, the thumb rule is that if the player is unconscious, not responsive, and there is no such contact, it is sudden cardiac arrest until proven otherwise. So you have to initiate the gold standard treatment, that is the CPR. Now, of course, we have moved from ABC to CAB, so these things are all there. But chest compression is the first and most effective thing. The next important thing is that the AED, that is known as automated external defibrillator. What we need to understand that this AED is somehow a bit different than we usually see in hospital ICUs. So these are automated defibrillators. So once you put those leads on the chest of the player, it can prompt you. It can prompt you everything, like if your chest compression or the depth of compression, the rate, whether it is sufficient or not. Also, we need to understand that there may be a sudden cardiac arrest, which may be because of rhythm that is shockable rhythm, or the rhythm may be non-shockable. So if the rhythm is, and the machine can tell you each and everything. So if the rhythm is shockable, then the machine will prompt you to give the shock, and that is the only time you should stop that CPR. That is the only time. If the machine will tell you, okay, the rhythm is not shockable, then there will be no shock and the chest compression should continue. So that is the most important thing. And we have seen the thing that how the player has been recovered on the ground. The important thing to understand here that the time is so critical. If the player needs to be revived, it has to be revived on ground. It is not in the hospital. So whatever facility, teamwork, whatever is required, proper training, it has to be done thinking about the scenario on ground. Another thing that has been come up, not that much, I would say, popular, is that there is a machine called automated CPR. That is, the machine will itself give you the chest compression. So even though the hands-only CPR is still the gold standard treatment on ground, but this thing can be tried, and the manufacturers, they are claiming that these are even more important, especially in those areas, in those situations where CPR may not be possible, like when you are mobilizing the patient, or in case of those scenarios, maybe in the ambulance where the chest, the head only CPR might not be possible. So that thing can be considered. That is called the automated CPR machine. Otherwise, the AED and the hand only CPR is the gold standard treatment, of course, in this kind of scenario. Yeah, back to you.
Great. So there is something called as an automated CPR machine, which is being developed. That's like a new trend to us. We'll see the results, obviously, because it's not being used like routinely. So hopefully we get some good literature support on that in coming years. Moving on to Dr. MARGOT, bringing to my favorite question: what is the role of technology in assessment of these concussions, sports-related concussions, and do you see any application of technology for diagnosing and assessing it, and in management of those concussions?
Yeah, thank you. It's a very challenging question, and it seems like
because technology is evolving each day, and everybody's talking about technology and data and all those things. So I thought that it to be bring it to here to discuss that what would be the role of technology in assessment of these sports-related concussions, and is there any change that we are looking at in next 5 years?
Yeah, I think it seems like every week or month, or there's a new technology that's come to the forefront, and it's going to be the silver bullet, right? It's going to be the one thing that allows us to sort of make this diagnosis quickly, and especially on the sideline. Again, as a team physician, you're under a little bit of pressure to try to make a diagnosis that I think still remains a clinical one. But I think, there are some new advances. And again, I really think that the spotter programs, which their technology, right? The medical sideline review, I think has been huge, especially in terms of professional sport. In the United States, this includes, Major League Soccer, National Football, the National Hockey League, and National Basketball Association is, using this medical sideline review technology that is really helpful in providing slow motion and eyes for the team doctors. But again, concussion is challenging because if a player has a clash and they feel dizzy or have a headache or they're confused, it's easy, right? You don't need any technology to tell you that the individual has sustained a concussion. But the challenge is when the symptoms might be delayed, the signs might not be evident. And, that's where we sort of fall into trying to sort out, are the symptoms that someone is experiencing a day later, are they a concussion or are they something else? Because the symptoms themselves are not specific to the injury. So you could have an athlete that's fatigued, dizzy, not feeling right, and they might have a cardiac issue, right? So again, that's where this diagnosis is a challenge. There are some recent technologies that I think are emerging and are being piloted. And the scientist in me is a little bit of is cautionary. So I'm optimistic that some of these technologies will be useful, but they've not been validated yet for use. And that includes quantitative EEG, sort of a skull cap that players can put on a sideline and has been evaluated for use in diagnosing concussion. The salivary microRNAs, so saliva biomarkers that are being piloted in several different countries, and then functional near infrared spectroscopy is another sideline technology that's been emerging. And then there are a lot of different handheld apps that use technology to assess cognitive function, whether that's orientation, memory, concentration, recall. There are apps that measure reaction time or balance or posture assessments and other oculomotor vestibular function. And so there's a lot of exciting work on the horizon. Every 4 years, there's an international concussion and sport group meeting. It was supposed to be held in 2020 in Paris, and it was delayed, and it's now going to be in Amsterdam in 2022. And as part of that process, we basically do a systematic reviews on a lot of the components of concussion, evaluations and return to play, and sideline technology is certainly a big component of those reviews. So more to come in terms of really having the science behind what's the best technology. And my sense right now is it's still multimodal. It's not going to be one silver bullet. It's probably going to be a multimodal assessment.
Yeah. Technology has its limitations too. But the reason why I asked you this question was, we being sports physicians, we need to have something like an objective thing apart from our clinical judgment to prove it to our management people who are just sitting ahead, on our top of our head, so that we give out something. So, with the advancement of technology, with the imaging technology, a lot of radiologists could give, evidence for musculoskeletal injuries. So that's why concussion being one of the important aspects of sports and football, if at all is there any technology or any objective mapping to it, we would be certainly having some sort of relief in making decisions which are always clinical. But to support that, it's a sideline thing. It's one of the important aspects. Coming back to Dr. Grimm, I know my knowledge about the non-intentional accidental injuries is limited, but do you see any use of technology that is developing or maybe developed, or any of these things that you can think of or maybe considering in your research group or research lab that would help to overcome the problem, and at least not overcome the problem, but to map it, or bring any meaningful solution to it?
Yeah, you see, I was just looking at your excitement when you asked Margot about new technology. So I'm afraid you're in for disappointment with me, but because my view on that is not about sophisticated novel techniques, but then I think also in our environment, we need to think of access to these technologies, right? So I think the one item I would like to suggest, I think might have the critical advantage that it can be made available and is easily accessible to players across Africa and Asia, because all they need is a mobile phone. So what we have learned is that groups and communities play a vital role in encouraging, supporting, and advising survivors of abuse, not only initially, but throughout their healing process. So these virtual communities and environments are teaching us that technology can help facilitate group formation, engagement, and healing. So if you look at Africa and Asia currently, it will be very difficult for us to assess the availability of local networks, that provide us the infrastructure for referrals and education. And I think in this setting in particular, broader remote learning communities can create a platform and create connectedness and information sharings where players otherwise might not know where to turn to. So such groups can convey a sense of belonging and say, you're not alone in this, right? And then this should obviously include positive messaging, where we underline the beauty of the game and promote the countless benefits of sports, because obviously we don't want players to withdraw and see the game as this dark place that has nothing to give to them. It should definitely include educational messages to say what behavior of my coach or my physician is okay and what is not, because I think that might be, especially for child and adolescents players, might be very difficult to distinguish. It could include stories, player models, and peer outreach, that literally extend a virtual hand and instill courage and self-worth. And it could also include links to organizations outside of sports that work in interpersonal violence. So we see great potential in this application of technology, while we still learn about the different setting, cultures, and barriers, and still need to build the local infrastructure and in-person expertise in Asian and African sport.
Yeah, sure. So I think you are suggesting here all the technology giants who are attending GSC that yes, make some software and use of mobile to create certain group with some privacy so that we can bring out the, the problem, highlight it, and try to find a possible solution to it. Moving on to the next question. Yes, Dr. Mallick, I'm coming to you. So as we see, there are a lot of, we discussed about concussion and sudden cardiac arrest and all. So often we see on football field that players are clashing each other, and sometimes they have a concussion, but sometimes there is an elbow which is, being hit, and that might result into a nasal injury, particularly epistaxis. In soccer, if you want to speak on that, do you see any different management or any advancement? Because your experience with boxing would have put you at an advantage where you would have learned about something, managing new techniques of, nasal injury management. So something which you think about application in football, and you see anything in football which will be growing up?
Yeah, of course. And I just want to begin where exactly Dr. Margaret has left. That is the same incident that can cause the concussion can also cause this epistaxis or nasal bleeding. And as we all know, in football, it is the most common cause of concussion is not the head to head, rather it is the elbow to head, and that can also cause this nasal bleeding. So yes, it can be a very easy thing to manage sometimes, but it can be a bit troublesome. Now, as we all know that if the bleeding is on only the anterior nasal bleeding, it is easier to manage. Only a digital pressure can stop that bleeding, because we need to remember that if there is any active bleeding, the player is not allowed to participate. So the player has to come to the sideline, the bleeding needs to be stopped, then only he or she can enter into the ground. That means that you need to stop that bleeding as early as possible, otherwise your team will be playing with 10 players. So that's how the prompt stoppage of bleeding is important. So if there is no posterior bleeding, then the bleeding can be stopped on the sideline, and the player can be sent onto the ground. So as I have already told that the digital pressure is sometimes sufficient for that. But nowadays there are, in fact, if you see in boxing, they are using even adrenaline soaked gauze piece or cotton piece also. But there is something called chitosan that has been a recent thing, that has been not recent, it has been in the market for some time, but now has been used in case of the anterior nasal bleeding, which is nothing but a protonated bioadhesive molecule which interact with the blood and create the clotting much faster. So it's nothing but a stick sort of thing. You can put that into the nostril and you can leave it there. The player can be allowed to play the game with that stick inside, and it stopped the bleeding relatively earlier. But again, you need to take care that there is no posterior bleeding, because that is an emergency and that needs to be treated in an emergency situation or emergency room. So otherwise, the use of chitosan is really is helpful nowadays in football, in boxing, this kind of combat sports. If I can call football as a combat sports, so yeah, that is really helpful nowadays. Yeah.
Yeah. So we'll come to that, exciting thing to learn. Dr. MARGOT, being an insider of many of these, bodies which are regulating football, and having worked with, this Major League Soccer, how do you think should be an ideal management of concussion case, if at all it is there? And what would be the challenges from viewpoint of a sideline physician as well as the chief medical officer? Both the roles are different, and what would be the different challenges in management of such concussion case in an ideal scenario?
Yeah, I think, I mean, you hit on it in the comment that you made related to the last question, where a lot of times, the team physician on the sideline is under a lot of pressure, and there are not, unfortunately, we have had situations where a player might be obviously lying motionless, not being able to protect themselves. And when they're initially evaluated on the field, they might not know the score. Like thematic questions are sort of the part of the SCAT that Dr. Grimm was talking about. We do have a standardized assessment, it's called the SCAT. And part of that is thematic questions, asking what venue are you at? What's the score? Who we play last week? Did we win? But you can have a player that has a mechanism, observable signs, and when the team doctor gets out on the field and says, do you know what the score is? They don't. They're obviously confused. They're obviously concussed. But then by the time you bring them off to the sideline, the player is like, I'm fine. Put me back in. So I think that remains the biggest challenge. And some of it is just having the support, and this is why it's so important for anyone that's working as a team physician, even if they're working at the very low levels. But if you're working for a lower level school and you're the team doctor on the sideline, it's important that before you get into a game situation, that you've that you have the authority, you're the team doctor, and you have the authority to stop that player from returning to play. And that really needs to be made clear. And I know that that's, you know, one of the issues that FIFA was dealing with, you know, after the World Cup, is just being able to give that authority to the team doctors. So to answer your question, I think that the biggest challenge is that it still remains a diagnosis that does rely on clinical judgment. And if the player is not right, if the player's just, you know, confused or not themselves, you know, this is an important injury. We have to err on the side of being cautious. And I think the other piece is just having a standardized approach. You know, there are a lot of guidelines. There are the concussion and sport group guidelines that I mentioned. The team physician consensus statement was recently published. And again, those all have come up with the same conclusions as it relates to return to play. And I think one of the areas is still controversial is just determining how quickly can a player return to activity safely. You know, does it need to be gradual with the incremental increase in not only the risk for exertion, but then also the risk for contact. And I think all of the consensus agreements agree that that it should be this sort of, you know, several day progression, but there's not a lot of science behind that. So I think where we are is that we agree that a standardized approach to the evaluation is important, and then a gradual return to play. You know, once after the first 24 to 48 hours of relative rest, you start to exercise, even if they're symptomatic, but you don't put them at risk for contact until they're back to their normal cognitive function, baseline level of symptoms, and, you know, postural stability, et cetera. But I think that's the biggest challenge, is that we really don't have a standardized approach that's based on science, right? It's based on what we think makes the most sense, right? Because you'll have coaches that will argue, wait a minute, their cognitive function is normal, they feel fine, it's only been 3 days, but so what, right? And it's hard to have a scientific response to that, because as of yet, there's no science.
That's why I was asking you that please discover some technology so that we have something to rely on, because at times when we are defending our clinical judgments with the coaching staff and with the management team, we find sometimes ourselves in difficulty when dealing with such cases, when we are especially a sideline physicians.
But I agree. So to your point, I think it's really important for anyone that's working on the sideline to be very rigorous, be very complete in your evaluation. And, you know, the SCAT is a good example. If you're able to, if you actually perform the SCAT, right, then when you come to the sideline and the coach says, what do you mean he has a concussion? He's fine. You basically say, no, he didn't know the score. You know, I mean, so if you do your due diligence, and if you're complete in your evaluation, I think it does give you the information that you need to be able to say, this is, you know, my clinical judgment, but it's based on, you know, it's based on how he or she performed on that assessment.
Yes, sure. So moving on to Dr. Grimm, you have been working with Aspetar, you know, a FIFA Center of Excellence, and also the FIFA Medical Office. How do you see that, you know, these organizations and their working style and their working culture you must be aware of? So do you think that for the non-accidental injuries that we spoke about a moment later, they have a certain, you know, kind of a project allotted, or they are considering it as a non-accidental injuries is significant, and they want to bring out some, you know, reforms or policies in that matters? Or, I mean, whether they are really willing to allocate resources, because ultimately what we speak about is just pure science and our passion, but the thing that drives everything is the resources, the money behind it. So these organizations, really, they are ready to fund all these things. I mean, is there any mindset of that, because you being an insider from that?
Well, You see, I think there currently is an enormous momentum out there, you know, where it comes to non-accidental injuries. I mean, it took us so long to move from accidental injuries to consider disease, to consider mental health, to consider, you know, wet as, and now we have the IOC statement on safe sport. So I think that is a movement that cannot be stopped. And then if you look at FIFA, I mean, they have done quite a lot of work. I mean, they have their own safeguarding unit now with very experienced people. Joyce Cook, who's running it, who's trying to look at a central agency where, you know, that might deal a global, maybe similar to the WADA model, you know, where these cases could be supported and reported. That might help with the resources that we thought about, because, you know, as you say, we currently don't know what is out there, especially in our continents. And then the other point is, you know, in how far are football associations willing to invest in that? You know, I think it's still at this point, the national team, you know, is where all the resources go, and then other projects are like negligible too.
Yeah,
but
Dr.
if you
Grimm,
see the,
yeah, I would like to add one more question here, that looking at the Asia and African context, where there is a cultural difference as compared to the West, where people are more vocal. Do you think that it will be that easier to bring out this reforms and changes in these continents? Because we have very good players from Africa who are playing, you know, for European clubs, and they might be victims sometimes, and they may not know about it, or maybe have never reported about it because of their socioeconomic status and you know, the other problems, the cultural differences too. So how do you see this problem being in Asia and African context?
No, I think you're absolutely right, you know, and I think that is why we cannot just take something that works in the US setting or in the European setting and put it, you know, in Asia and say, here. So for example, there was an amazing survey done by a German psychiatrist among elite German athletes on sexual abuse and abuse in general in sports. But the questions there were so direct that, you know, clearly there's no way we could use them in, you know, in some Asian countries, African countries. So that is why we really need to involve, you know, people who are on this call today, people in the regions who work on the ground, and work together with them to find out how could we approach this in the different cultural contexts. So there is a lot of work to do, and there's surely no easy answer. But you know, on the other hand, these players who play overseas might play a very important role in that, you know, by encouraging the conversation about this topic. And I think that remains one of the most critical tools we have, that we actually start talking about this.
That's really, you know, we have to think about it in an Asian context and an African context particularly. Which brings me to another question to Dr. Mallick, that from Indian perspective, or from, let's say, from Asian perspective, we are, but it sometimes happens that we do things at the last moment, and we take it to be granted sometimes. But obviously this cannot happen in a football, you know, at elite level, and we need to be prepared in such scenarios. So what, according to you, would be a best practice for the medical team to prepare for the match day? And, you know, is there any kind of a best model that you would say to prevent, you know, the injuries, and if at all they happen, then to, you know, take care of them in the best possible way using the latest approaches?
Yeah, that's a very pertinent question. In a game like football, which is a very dynamic sports, when your team is preparing for the match, the medical team also needs to be prepared for the event in the same way, if not more. Now, there are a few models. I just want to refer one a very good paper that was published 2-3 years back in British Journal of Sports Medicine regarding a model of best practice. Obviously, the paper was from England. Model of best practice when you are covering a football match, how the medical team is preparing for that. And they have come up with a concept called board, where your team is, being a team leader, how you will prepare your colleagues, how you prepare your paramedics, how will you prepare your necessary equipments, how you ensure that regular training is going on. So all these things are there, which is very much important, because the incident that we are discussing here may not be that frequent, but when they come up, they will come up with a challenge for the medical team. So you need to have all these things in place: your preparation, your equipments, and the training of the medical and paramedical staff. So what they have suggested 2 different scenarios and 2 different teams. Even though the team members may be the same, it is the roles and responsibilities that has been designated to them. One team is for general injury management. It may be anything for that matter. Another team is for sudden cardiac arrest. Okay, so again, the members can be the same. It is the roles and responsibility that has been designated. So in the general injury management, the teams are designated like who will do the spinal stabilization, who will take care of airway, breathing and circulation, like that sort of thing. In case of sudden cardiac arrest, of course, who will give the chest compression, who will look after the breathing and all. So they have come up with these 2 models, and then another member who should be given the responsibility of AED. Then another person who can be, of course, it all depends how many members are there in your team. That also very important. And another person is given the responsibility of the oxygen. And there are 2 more things. If you have sufficient amount of paramedics, then one is for your stretcher or the spine board, who will carry those things, who will be on the head position, who will be in the trunk position, who will be in the feet position. And if you require a log roll technique, again, who will sit where. So all these things should be practiced, should be done prior, so that if the situation comes on ground, then your team is absolutely prepared for that. So there needs to be some mock training. At least they have proposed weekly once for the entire team. And all the roles and responsibilities needs to be changed, so that each and every member of your team is prepared for each and every scenario. So the thing, but before you are going to a major competition or major match, or on the match day, the roles and responsibilities should be written, that today this person will be taking the responsibility of this thing, this person of that thing. So that is important. So even though they are practicing each and every role, but it is important that on the match day, you are giving the responsibility, being a team leader, you are giving the responsibility to a certain person of certain thing. So that is very essential, that the training and preparation is the most important thing. As they always said, that hope for the best, but always plan for the worst.
Yeah, sure. Yes. Education and accountability will surely take care of a lot of things and mishappenings. So moving to Dr. MARGOT, being from the Major League Soccer and a chief medical officer, and from the United States, where we look upon for guidelines and standardized treatments and standardized procedures and protocols, how do you often see, a kind of a mismanagement or, lack of preparation in terms of management in handling the field side injuries in your setup? And do you have anything in place to check it, to put it back through, the latest advances that we have, like the mannequin being taken for practicing at the student level, and certain technological support like HoloLens and all being coming up these days to give a simulation lab and experience that it's not being explored in sports per se, but in many of the fields of medical, this medical things, they are being explored, and simulation labs are being set up. So is there anything in as per se in United States which may translate down to our developing nations in future?
Yeah, I mean, I think that Dr. Mallick actually touched on some of the things that are being used, and the importance of, I mean, we call it a emergency medical or emergency action plan, right? That you have to have, and no matter what the level, again, it could be at the elite level, but it's also at the community level if you're covering, the 12-year-olds that are playing sport, right? That you need to have an emergency action plan that's written, that's practiced. And it might be that at the elite level, you have, 5 doctors and an ambulance and an airway management team. Whereas at the community level, you're lucky if you have sort of a healthcare provider that we call them athletic trainers, but I think in Europe they call them physios, right? Like you're lucky if you have anybody that's got any medical training. And it might be that you just have somebody that's sort of an adult that knows CPR, right? Or knows first aid. But I think having an emergency action plan that is practiced and that, as Dr. Mallick pointed out, has all of the equipment and the roles and responsibilities sort of worked out is important. And then I think as it relates to, I know that when I recertified for my CPR, there was a device that, that was on your phone, that it told you whether your compressions were deep enough or whether your rate was, the appropriate frequency, et cetera. So, I think there's a lot to be said for planning. There's a lot to be said for, having those emergency action protocols in place that evolve, right? I mean, think about all the changes that have occurred in the last year. All of our emergency action plans now included COVID. What are you going to do when someone gets sick on your sideline, or what are you going to do to protect the individuals that are that are coming to attend the event? So I think that those are the biggest takeaways that I can think of.
Yes. So it's a wonderful session which is going on. Unfortunately, I'm getting some message from the back end that we are nearing our time. So won't be able to take more questions, but just as a concluding remark, Dr. Grimm, would you like to add something on today's theme and today's discussion?
Yeah, no, thank you again, Dr. Amol. As I said, I think conversation about this uncomfortable topic and our role as sports medicine physicians are one of the most critical tools we have. So I really hope we can continue talking to the colleagues in the session today. And I would like to encourage everybody to visit Sports Equity Lab website or get in touch with us via email or social media so that we can really include the perspective of African and Asian colleagues and athletes in that, because otherwise, we are beside.
Sure. We do understand, and I'm sure the attendees would be taking a note of it, and the interested ones would be reaching out to you. Moving on to Dr. Mallick, your closing remarks on the session.
Yeah, it's a great session, and it's a great privilege to interact with the leaders of their respective fields. And I really believe that the attendees will be really beneficial for the with the discussion that we have done. And of course, all the 3 topics that we are discussing here that are important in today's scenario. And I believe there is a road ahead and I believe that we can continue the same thing in future also. Yeah.
Great. Thank you, Dr. Mallick. Now coming to Dr. MARGOT, your closing remarks. But before that, moving on to next year's concussion study group and the consensus. Are we expecting something new at that time? Some new additions that are already being in discussions, and where we are heading in terms of concussion management, which is yet to come. But you being part of that, a small note on that and a concluding remark from your side.
Okay, well, I'll start with the latter. I just want to, thank you for the opportunity to present with these experts, and it's really been a pleasure. I think that the topics you've chosen were extremely important, so I just want to thank you personally for the invitation to participate. And then in terms of the concussion and sport group meeting next year, I'm very excited. I mean, it's been very challenging to have it on hold because, as I mentioned, we do these systematic reviews for 11 or 12 different topics, and they're all based on the evidence. You're sort of scouring all the papers that have been submitted, and then when you delay it a year and delay it another year, we're sort of putting in place. Okay, we're going to do our initial review and we're going to write our initial paper, but then we're going to have to do another review next January in preparation for the following fall. But I'm not sure. I mean, I think it's a very interesting topic, and sometimes we see some changes that occur, and I think there will be some changes that occur as it relates to some of the sideline management piece and some of the office evaluation piece. And hopefully there's so much work that's being done in this area that I hope that we're moving forward. Sometimes it feels like we're standing still, but I am encouraged. There's just a lot of really smart people, way smarter than me, that are putting their head into this, no pun intended, into this topic. So.
Great. We are waiting for that concussion statement to be released to know more about it, understand more about it, and then educate our athletes about it, and the teams and the coaching staff about it. Because ultimately, as you rightly said, that the diagnosis lies clinical, and there is no substitution to it. So it's the team physician's call at the end, and that he has to justify he or she. And that will, bring out the outcome on that person who is already concussed. Whether he will play or he will not, that's a different story. But putting athletes' life first and putting out, preferences, I think we always choose the player's health as the first thing, and try to do justice as our role as team physicians, and help in the diagnosis and the correct management of concussion, which is an important injury on the field. Thank you all for being here, and it was a wonderful discussion. Unfortunately, because of the time constraints, I have to cut it short, but would love to discuss it some other day on the same platform. Maybe in the next 6 months, we are hoping to have another conclave, and we'll love to see you there. Thank you once again for all.